listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12.
You hear a sports podiatrist meeting with a patient referred by his GP.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, it is Mr. Godfrey, correct?
Yes, that's correct, but you can call me Vance.
OK, Vance. So, you were referred to me today for an ongoing complex heel condition in your right foot.
Yes, that is correct. I was diagnosed with plantar fasciitis 2 years ago.
Yes, I saw the ultrasound report you sent in, which showed you have a mild case of plantar fasciitis. So, where are you feeling the pain exactly?
The pain is under the base of my heel, in the centre. I also have started to feel pain on the side. I have noticed that when I just twist my ankle a bit, the pain starts on the side of my heel.
And how does your day start off in terms of the pain in your foot?
Well, my day starts off pretty painful. I feel a significant amount of pain when I place my heel on the ground. But then the pain under the base of my heel goes away within the first 10 to 15 minutes of the day.
What about the pain around the lateral side of your heel?
That continues throughout the day and does not seem to ease at all.
OK. Any recent injuries?
Yes. I have had 3 ankle sprains in the last 6 weeks. I went to another podiatrist but didn't receive any help. That podiatrist advised me to apply ice packs to the base of my heel and to roll my heel on a hard object like a golf ball, and to take anti-inflammatory medication to reduce the pain. I've tried all of these, but I haven't seen any changes. That's when my GP referred me for an X-ray of my foot, which didn't show anything significant. So that's why I'm here, keen to get a second opinion. It has been quite frustrating dealing with so many doctors and getting nowhere.
Yes, I understand. So the pain that you're describing as being under the base of your heel is consistent with plantar fasciitis, but the other pain that you describe around the lateral side of your heel is probably not related to that, and for that reason concerns me more. Based on what you've told me, I suspect there is some pathology with the tendon of the abductor digiti minimus muscle or the sural nerve. I'm going to order another ultrasound to assess the area in more detail.
OK, I see. And if the ultrasound comes back the same as before?
We will have to wait for the results. But in the meantime, I'm going to treat you for plantar fasciitis to see if there is any improvement in both of your conditions. I'm doing this because there is a small chance that the pain you're experiencing laterally is a referred pain from your plantar fasciitis. So I'm going to have you fitted for an immobilization boot, which will reduce the strain on all parts of the heel and allow for rest and recovery.
OK, I have a question. A friend of mine went to see another podiatrist and received a new treatment. I think he told me it was some injection therapy.
Yes, I can perform that treatment, and it does have some benefits as a diagnostic therapy.
Could that happen today?
Oh, yes. It would consist of injecting 3 millimeters of xylocaine into the lateral area of the lower fibula in order to block the sural nerve. You should be able to tell right away if your symptoms have improved, and then you should continue to monitor your pain levels for the next 24 hours.
I would like to go ahead and have the injection, but first...
Extract 2, questions 13 to 24.
You hear an obstetrician talking to a woman about her pregnancy.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Nice to meet you, Mrs. Jackson.
Hi, you can call me Alison.
Okay, very well, Alison. So today will be your first ultrasound, is that correct?
Yes, first ultrasound and first pregnancy. A lot of firsts today.
Yes. So, before getting pregnant, Alison, did you often have irregular menstrual cycles?
No, I was always fairly regular when it came to my menstrual cycles.
Okay, and how about the pregnancy so far? Any complications?
No, not at all. So far my pregnancy has been fairly uneventful. Very little morning sickness, and just in general feeling a bit tired, but that's all. Everyone keeps telling me how lucky I am, particularly my mother, who says she had a very difficult pregnancy when she was pregnant with me.
Well, that is fairly standard. So, since you became pregnant, no vaginal bleeding or anything like that?
No, none at all. No periods or spotting at all.
So, let's see here. All of your vital signs are within normal limits, including blood pressure, and your chest examination is normal as well. According to your file, you are 23 weeks, is that correct?
Yes, that is correct. 23 weeks.
Something is a bit off here. Your fundal height exceeds what is expected for 23 weeks.
What is fundal height?
Fundal height is the distance from the pubic bone to the top of the uterus and is measured in centimetres. Generally, after 20 weeks of pregnancy, the fundal height measurement matches the number of weeks you've been pregnant. Your fundal height corresponds to 25 weeks of gestation, not 23 weeks. Is there any possibility that you miscalculated the date you got pregnant?
No, I'm fairly certain about the date. I don't really want to get into it, but yes, I'm positive that I have the correct date.
Well, when we do the transabdominal ultrasound, we will get a better look at what might be going on, but I do want to tell you that a uterus that is larger than expected for the corresponding gestational age can be a clue that the fetus or something else within the uterus needs a closer look.
What does that mean exactly?
It could mean a number of things. In this case of you measuring larger than expected, it could indicate too much amniotic fluid, which could cause shortness of breath or preterm labour. Another possibility is that your baby is significantly larger than average, or is in a position that is making the measurement larger than what it should be. There are some more serious possibilities as well, but I won't get into them unless necessary.
I could be having a really large baby? My husband was a really large baby.
Yes, that is a possibility. Fundal height measurements are a tool that we use to gauge fetal growth and to know that the baby is growing at a steady rate, but it is not an exact science, as there are a number of things that can make it less accurate. That is why we'll do an ultrasound to get a better look.
Okay. All of this is quite scary, but I guess everybody feels this way with their first pregnancy.
Yes, that is quite right.
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear an intern ask a senior doctor about a patient's treatment.
Now read the question.
Dr. George, can I ask you a minute about something that was said in the morning briefing?
Of course, Stephen. What is on your mind?
The patient with testicular cancer. He reported experiencing painful numb fingers and toes. I was not aware that this was a side effect of his current treatment.
Oh, yes. Painful numb fingers is not one of the common side effects like nausea and vomiting, as it occurs in less than 1 in 10 patients. It is a less common side effect like deafness, especially to high-frequency sounds.
Okay. Also, I was surprised not to hear hair thinning among the common side effects.
Ah, yes. For this particular cancer treatment, hair thinning is quite a rare side effect, affecting less than 1 in 100 patients.
Question 26.
You hear a doctor explaining the side effects of a treatment to a patient.
Now read the question.
So, Mr. Norman, I'm going to talk you through your prescribed treatment. You will be receiving chemotherapy drug given by drip over 24 hours. The first course of chemotherapy will happen next week 1 of your treatment, and the second course will take place in week 4 of your treatment. First, I'm going to go through the side effects. So, most importantly, Mr. Norman, you are at increased risk of serious infection while you are having chemotherapy. Minor infections can become life-threatening in a matter of hours if left untreated. So, we recommend that you use a digital thermometer so that you can check your temperature. You will also likely become anemic during your treatment, which may make you pale and feel tired and breathless.
Question 27.
You hear a surgeon talking about an optional training.
Now read the question.
Hello everyone. Allow me to introduce myself to you. My name is Dr. Asaf, and I am a surgeon specializing in colorectal cancer and laparoscopic procedures. I wanted to talk to you today about why attending our training on colorectal peritoneal metastases is extremely important. First of all of the sites of metastases from colorectal cancer, colorectal peritoneal metastases have the worst outcome. More research has been done on other sites of metastases, such as the liver and lung, but it's only in the past decade we have started to focus on colorectal peritoneal metastases. Here at this hospital, we are one of 2 national centres that treat patients with colorectal peritoneal metastases. To share our knowledge of this specialist subject, we have created a special training. It is aimed at teams that make decisions around patients with
Question 28.
You hear a nurse talking to a patient about his upcoming hospital stay.
Now read the question.
Hello, John. So you are scheduled for surgery later today, and then you will be with us for about a week.
Yes, coronary artery bypass graft. Yeah, they told me 7 days.
Yes. Well, I'm going to leave you with this safety card, which will go over how to make your stay with us safer. It goes over 8 main areas, such as falls, prevention, blood clots, infection prevention, among others. I also encourage you to share it with any family members who'll be visiting you regularly during your recovery. I will check in on you again before they take you up to surgery, So please feel free to ask me any questions.
Thanks. This will help to keep me occupied while I'm waiting for surgery.
Question 29.
You hear a nurse explaining a new protocol for patient handover.
Now read the question.
Hello everyone. Today I'm going to go over the basics of our new protocol for handover at the end of a shift. In the past, we have always done handover the traditional way, away from the patient near the nurse's station. Generally, this type of handover consisted of one-way communication, where the nurse in charge gave information to the nurse taking over the shift. As many of you know, there is currently an unacceptable number of critical incidents and complaints from patients, relatives and doctors. In particular, there is a high level of dissatisfaction among patients, as they report feeling that they are not being involved enough in their care. This last reason is the key reason that has prompted us to switch to a bedside handover, which is a model that involves patients and has been shown to give nurses starting their shifts better insights into the care each patient requires.
Question 30.
You hear a training for optometrist.
Now read the question.
Hello everyone, and welcome to today's program. The objective is to facilitate a case-based interactive clinical refresher program in primary eye care for practicing optometrists working in eye care centres. This program is not appropriate for those working towards any type of speciality in optometry, as it is focused on routine examinations used to identify and manage eye conditions. The program is divided into case studies and workshops, each focusing on a different type of examination, such as a slit lamp biomicroscopy, optical coherence tomography, and ultra-wide field retinal examination. The course will wrap up with a roundtable discussion of the opportunities and challenges associated with primary eye care.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
You hear a doctor specialising in kidney transplants being interviewed about a new procedure.
You now have 90 seconds to read questions 31 to 36.
Hello and welcome to this session in Advances in Kidney Transplants. I'm very happy to bring my friend and longtime colleague, Dr. Kristin Vaughan, onto the stage. Please welcome her with a round of applause.
Thanks everyone for the warm welcome. I'm very pleased to be here to talk about my team's work.
So, you and your team have just published this new study in the British Journal of Anaesthesia. Tell us about what led you to conduct this research.
Well, we all know that damage occurs to a kidney during transplant surgery. This is due to both the loss of its blood supply and attachment to new blood vessels in the receiving patient. We also know that reducing the transfer time can limit this damage, but the transplanted organ is still less effective than before. So previous research has indicated that a natural protective reflex exists that limits damage to the kidney and, when activated, can help prevent damage to organs when the blood supply is stopped. We wanted to test a low-cost tool that, if successful, could be easily adopted across the NHS.
Okay, interesting. So, what was this low-cost tool that you decided on?
We decided on a standard blood pressure cuff, which is very accessible in all clinical environments. Participants, who were both donors and patients, wore the cuff at the top of their arm, which was inflated to a tightness to temporarily cut off their blood supply for 5 minutes, and then deflated 5 minutes. This was repeated 3 more times in order to activate the protective reflex.
Did you only work with patients in the UK? Also, how many total patients took part in this research?
In total, 406 donor-recipient pairs took part across 15 European transplant centres. So we worked with patients in the UK as well as across Europe. As I just mentioned, both donors and patients underwent the procedure I described, either 24 hours before or immediately before their surgery. Also, for comparison, one group of patients and their donors had a placebo procedure that didn't cut off the blood supply to the arm and therefore didn't activate the protective reflex. Also, one more important note is that because certain anaesthetics are thought to interfere with this reflex, the researchers conducted the whole procedure before any anaesthetics were given to the donors or patients.
So, let's get to the interesting part. What were the findings of your research?
So, just to give a bit more context, this was a study done over a number of years because transplanted kidneys have a lifespan of an average 15 years. It is normal to see a gradual decline in the kidney's effectiveness, so we wanted to see if that decline was the same for the participants of our study. So, we found that the preconditioning immediately before surgery boosted the transplanted kidney's effectiveness at the start. And even though there was some decline in the effectiveness of the transplanted kidneys over the next few years, these kidneys were still more effective 5 years later compared to what we had seen from kidney transplants over the years.
That sounds like promising news. I mean, if a simple procedure like this one can extend the lifespan of all transplanted kidneys, it has the potential to not only improve the lives of the patients receiving them, but also generate huge savings for the NHS by preventing the need for dialysis. So what follow-up research do you have planned?
We intend to conduct further research to investigate the underlying mechanism, as well as determine whether just preconditioning either the donor or the patient has the same benefit. Also, this procedure has seen mixed results in the past, so we want to investigate the possible reasons, such as interference from anaesthetics, to enable this technique to realise its huge potential and deliver enormous benefits for patients with kidney transplants.
Those are very important areas to consider. It will certainly be important to understand the underlying mechanism, as that can inform research into other types of organ transplant.
Yes, that's definitely true. We have received a lot of interest from teams specialising in other types of organ transplant, and we look forward to working with them to see what other benefits this simple procedure could have.
Extract 2, questions 37 to 42.
you hear a presentation about research on allergies in children.
You now have 90 seconds to read questions 37 to 42.
Hello everyone, I'm very pleased to present today new research that North Shore Research Group will be conducting over this next year. Our research team will be conducting 2 related studies on potential treatments for children with peanut allergy. Just to get started, I will give some information about the rate of incidence and initial presentation of peanut allergy. In the UK, peanut allergy affects around 1 in 50 children, or 2% of all children. This incidence rate is similar to that of other developed countries, such as the United States, where it is reported that 2.2% of all children and adolescents have peanut allergy. This number has been increasing in recent decades. For example, a recent report from the US stated that in the 2010s, roughly only 1% of all children there had peanut allergy. The first sign that a child has a peanut allergy is often with a mild reaction, such as hives anywhere on the body, or a tingly or itchy feeling in the mouth. However, in rare cases, exposure to peanuts can trigger anaphylaxis, which is a severe reaction that affects breathing and can be fatal. In addition, common comorbidities among patients with peanut allergy include eczema, asthma, as well as having additional food allergies. So these signs can help in the diagnostic process. The first new approach that our team of researchers is investigating is known as immunotherapy or desensitization. The main goal of this treatment is to see if gradually introducing peanut-based treatments can help children build up a tolerance to peanut. In particular, the doctor leading this study wants to see if children aged 1 to 4 years with a peanut allergy can become less sensitive to peanuts by gradually increasing the amount they eat. Children who take part in this research will be given a small amount of special peanut flour mixed with food, such as applesauce or yogurt. The amount of peanut flour will be increased every 2 weeks until they reach what is being called a maintenance dose. Half of the children in the study will be given the active product, and the other half, the control group, will be given a placebo. Both groups will be monitored closely throughout the study with face-to-face visits at the research clinic and phone calls to check on the child's progress and to ensure that the doses are being well tolerated. The end goal is for children to be able to tolerate the equivalent of a whole peanut. Current treatment for peanut allergy is complete avoidance, which is not always easy and requires constant vigilance to prevent accidental exposure. While there is more awareness of the increasing number of children with peanut allergy, it is an almost impossible task for parents with small children to prevent all accidental exposure. In fact, accidental exposure is even difficult for adolescents or adults who are fully aware of their condition. Making children bite safe so that they don't have a severe reaction if they accidentally eat a small amount of peanut is one of the end goals of this treatment. The other related study that we are conducting on this topic is to see if young children can develop a tolerance to peanut through a peanut skin patch. Children taking part in this study will wear a patch that will expose a small area of their skin to a peanut protein. They will wear this daily while being closely monitored by the research team. This approach, involving a patch rather than actually ingesting peanut, may work better for the many children with a peanut allergy who have developed a strong aversion to the smell and taste of peanut. Both of these studies come out of recent research that proves old guidelines wrong. As I said a moment ago, for many years, guidelines and health professionals have recommended children with peanut allergy avoid it completely. However, more recently we have seen that controlled exposure to allergens can help patients develop a tolerance. The idea is that by exposing children to a small amount of peanut when their immune systems are still working out what is and is not harmful, will allow us to teach their bodies to accept it and not become susceptible as they grow older. Clinical trials started last November, and it will take some time to conduct the trials and analyze the results for both of